Good morning or good afternoon. I would like to thank Dr. Jabara as well as the member of the scientific committee for inviting me to participate at the Lebanese Congress. I'm sorry that I'm not with you. I'm gonna share with you the first topic, which talk about the scores in pediatric anesthesia and which one we can implement in routine clinical practice. I have no conflict of interest to disclose, except that I'm on the board of the WFSA, and I would like to take this opportunity to invite you to participate at the World Congress, which will take place in April in next year in Marrakesh, in Morocco. So coming back to our talk today, when we do preoperative assessment in anesthesia, the aim for us is to assess the risk, meaning what is the risk that can be predictable and therefore we can prevent. For example, this is the perioperative respiratory adverse events like laryngospasm, bronchospasm, hypoxemia, or also postoperative nausea and vomiting. Otherwise, we have some risks that are predictable, potentially due to the surgery or potentially due to coagulation problems, but we cannot really prevent them. And finally, we have the unpredictable, unpreventable risks. What's important for us is that we need scores. If they need to be useful in clinical practice, they need to predict perioperative adverse events and thus be able to prevent their occurrence. They also need to be able to guide our decision. They may direct additional preoperative clinical or paraclinical assessment. Unfortunately, today, we are missing scores that may be able to predict long-term outcome, which this would be actually nice to have also. Before talking about scoring, I think it's very important to differentiate risk factors from scoring system. Risk factors usually help recognizing patients who may be more vulnerable, whereas scoring system help estimating the probability of complications or mortality, for instance. In any case, ultimately, risk factors and scorings will guide clinical management. So when we talk about risk factors associated with some complications, we're talking about some variables. They may be qualitative or quantitative assessment. They identify potential risk, but they can help in the clinical judgment. Whereas scoring is usually a structured tool, it's always quantitative and give you a numerical score. It does quantify overall risk, and actually it provides somehow a standardized risk estimation. But to be honest, when you assess preoperatively a child, the use of risk factors and the scoring system should be complementary. So you have a overall assessment of the risk of the adverse events or complications that may occur. So let's go for the first scoring that has been formally validated and applied systematically in clinical practice. In other words, all over the world, each child has got this score. Probably you know what I'm talking about. This is the Apgar score. It's very important to talk about the Apgar score because it was developed in 1952 by an anesthesiologist. That was Dr. Virginia Apgar. If I can recall, she was at Hopkins, she was an obstetric anesthesiologist, and her score is applied all over the world. And it assesses 5 criteria scored from 0 to 2 that you know very well: the appearance, the pulse, the whether there's a reflex irritability, the activity, and respiration. It's a universal assessment tool that guides immediate clinical decisions. However, it does not allow any, or it is not associated with not allow any medium or long-term outcome. The other score that was developed and created very early, and that was in 1941 by the American Society of Anesthesiology, and was revised in 1961 in its currently how we are using. It's the ASA physical status classification. It's actually a qualitative and semi-quantitative score. It does describe preoperative physical status and not the anesthesia risk. The problem with the ASA physical status is that it's actually very subjective when you assess it, and many studies have demonstrated the poor inter-rater reliability. Also, there is a lack of pediatric specific criteria. Having said this, I will come back to it immediately after. And actually, used alone, it does not predict the perioperative risks. Lynn Ferrari from Boston Children's Hospital in about 5-6 years ago developed with the Society of Pediatric Anesthesia the ASA physical status that is adapted to children with some pediatric definition. You have here a summary. You can find it actually on internet. I'm not gonna go into it, but you can see, for instance, that severe obstructive sleep apnea, meaning that the child who has an index of apnea, hypopnea of over 10, it's ASA 3. And whereas mild moderate obstructive sleep apnea, for instance, is ASA 2. And you can see that the age here is also introduced, and any infant less than 6 weeks is ASA 3, even if he's healthy. So it's very important to know that today we need to use, when you are assessing a child, you need to use the ASA physical status with the definition, the pediatric definition of the ASA physical status. A further study done in 2021 by Lynn Ferrari has demonstrated that applying these definitions led to a lower variability between the anesthesiologists in the classification. So to be implemented in clinical practice, a score should predict severe adverse events and or complications. But what are the severe adverse events we're looking at? Well, when you go back to the Wake Up Safe study that was looking at more than 500,000 kids over 2 years in the centers that participated in National Pediatric Anesthesia Safety Quality in the US, they have demonstrated that respiratory events are the primary severe adverse events occurring. And among them, there's pharyngeal obstruction, and laryngospasm, bronchospasm. They may lead to cardiac arrest, beside those cardiovascular events from a variety of causes that lead to it. I highlighted here in red other causes of severe adverse events that are preventable. And that's why that we can every day predict and prevent. And when I go to Apricot study, it has demonstrated also that respiratory adverse events was the most frequently severe adverse events observed, particularly in the preschool children. So what do we have here as a score to predict such complications? Well, when you look at the risk factors that have been issued from these studies, ENT and obstructive sleep apnea were among the main risk factors. So identifying children at high risk of obstructive sleep apnea is essential. There is a score that is very nicely used by pediatricians, or sleep study people, which is the Chase Obstructive Sleep Apnea score in children. It does assess the severity of obstructive sleep apnea and the incidence. In adults, we have the stop bang, but that has not really been validated in children. However, in children, we have the STBUR questionnaire. This is based on 5 symptoms: snoring, trouble breathing, and unrefreshed. You can apply it every day when you assess any child. We have 5 symptoms: whether he snore more than half of the time, snore loudly, have any trouble breathing or struggle to breathe, stop breathing during the night, feel unrefreshed in the morning after a night of sleep. This questionnaire was strongly associated or predictive of perioperative respiratory adverse events in children at risk for sleep disordered breathing. So the presence of 3 symptoms of this scoring was associated with 3 times higher incidence of perioperative respiratory adverse events. The presence of 5 symptoms was associated by 10 times more incidence of perioperative respiratory adverse events. And this questionnaire has been validated in subsequent studies, even whether it was prospective or retrospective. Therefore, I really encourage you to implement the STBUR questionnaire in your preoperative and routine practice. Another score that has been developed a few years ago by Vivian Nasser was the PRAM scoring. That was a pediatric risk assessment score to predict perioperative mortality in children undergoing non-cardiac surgery. Following more than, as I remember, 110,000 children and applying multivariate analysis, they were able to isolate predictors and to develop the scoring that is based on 5 variables: whether it's urgent surgical procedure, whether there's the presence of comorbidity, for instance, the presence of respiratory disease, congenital heart disease, pre-op or kidney disease, neurological disease, and then you add a value of +2 to your scoring. Any critical ill child, if any presence of at least one of the following characteristics, like preoperative mechanical ventilation, inotropic support, or cardiopulmonary resuscitation, you have +3. Any infant less than 12 months, you add +3, and the presence of neoplasm with or without preoperative chemotherapy, you add +4. And what they found, that the PRAM score, which is a simple and objective tool, was a good predictor of 30-day mortality in pediatric patients. However, they found that a scoring system around 4 and 5, in 7% of the children, the sensitivity and specificity was less than 90%. Otherwise, the PRAM score had an area under the curve of 0.95, which is really good. And it was validated in another cohort of children. Unfortunately, we do not have any study or research done to see to predict more, other additional study for external validity of the score, since it had been developed and validated the year after. Now, a very recently published this year in British Journal of Anesthesia, a team from the US, using also a large cohort of children, have developed a score looking for postoperative respiratory complications in children. We're talking here about postoperative respiratory complications. And they were able, with the multivariate analysis, to identify 11 predictors, those related to presence of comorbidities, those related to the procedure itself, and those related to the patient. And you can see here, like for the patient, the body weight, whether he's BMI very high or less than fifth percentile for age, the ASA physical status, more than 3, and the age of the child, less than 2 years of age, were integrated in these predictors. In the comorbidities, whether upper airway infection, the presence of anomalies of the nervous or cardiovascular system or respiratory system, and the preterm baby. Similar predictor was found in nectarine, for instance. And finally, the procedure, we find again the emergency, the use of high dose of neuromuscular blocking agent and thoracic surgery and the lung surgery over 2 hours. What they found is that this score, which is called SPARC-C score, was a very good predictor of postoperative respiratory complications. However, the problem is that postoperative respiratory complications are not well defined in children, unlike adults. And in adults, we have a score which is ARISCAT, which is universally used because we know, and it's very well defined, the postoperative respiratory complications in adults. And the problem also, while these authors have validated internally and externally in another different cohort of patients, the area under the ROC curve was 0.85. Having said this, the score is, however, complex. As you can see, the numbers are different depending on the variable and the predictor. But the authors made it available with possibility of online calculator. So please remember the SPARC-C. I think it's a good step. This is the first study looking at postoperative respiratory complications in children. I hope that this score will be implemented in research in years to come, like the PREM score, so we can really see we can have good evidence about the value of these scores to predict mortality or postoperative respiratory complications, which are the main complications that we worry about in neonates, infants, and in children. Another simplified risk that we can use every day in routine practice is the simplified risk for PONV. You know that there are 4 items, 4 variables, risk factors, like surgery over 30 minutes, any age over 3 years, strabismus surgery, and history of PONV, whether in the child or relatives. And if the risk, if you have over 2 risk factors, there is more than 40 to 70% incidence of postoperative nausea and vomiting. This simplified risk is very useful. It has been highlighted in the literature and in the guidelines and serve as a baseline for the management and the preventive measures that have to be implemented to prevent from postoperative nausea and vomiting. So here we are also in front of a score that can help us predict and prevent from the occurrence of postoperative nausea and vomiting. Finally, the last score that I hope you are using on everyday basis, and also it has been developed in 1970 actually by Mr. Aldred, who was also an anesthesiologist in Florida, is the post-anesthesia recovery or Aldred score. It's based also on 5 variables scored from 0 to 2. It assesses actually clinically the physical status of patients recovering from anesthesia. It follows somehow, you can repeat it throughout the time or the length of stay of the child in recovery, and it follows the awakening process. It serves as a basis also for discharged patients, and we use it routinely, whereas in Geneva or in the US, in Boston, where I'm working now, we use it routinely. The nurses use it routinely to discharge patients for outpatients. So I've done somehow a review of what are the scores that are best validated and known in pediatric anesthesia with the goal to predict complications, intra or postoperative complications or mortality. However, if you go around and you see around our colleagues or what's happening, they are not implemented in routine practice. They are really, why they're not really implemented? Because potentially the validity and reliability of certain scores are often questions. Also, integrating these scores into the workflows is challenging. When you go to pre-operative assess a child, you do not think about applying these scores. When you look at some of these scores, which are really easy to implement, you could actually, but they are not integrated. Some of them are complex, I agree with you. And to be accessible, like you are not going to go to Google to actually enter and calculate the score to predict the post-operative respiratory complications. And as we know, there are time constraints. And unfortunately or fortunately, anesthesiologists often rely on their clinical judgment based on their experience and the risk factors that are identified in the literature rather than integrating a score in their routine assessment. That's why at the beginning of my talk, I said that risk factors and scores are complementary and they should be used together to add to the clinical judgment. It's actually an overall assessment of the risk in children. So what's the take-home message? So one should separate the scores that assess incidence or severity. As you see, I didn't talk about the pain scores because this assesses incidence of and severity of pain, or the PET score, which is applied for delirium to again assess incidence and severity. From those scores that I mentioned in this lecture that rather estimate risk and thus guide clinical management. What I believe is that some scores should be embedded in the electronic medical record and used systematically during a preoperative assessment. And among these scores, you have to implement the STBUR score, the PUNF score, the PRAM score, alongside the ASA physical status adapted to the children. In Geneva, we are actually entering the PRAM score alongside the ASA physical score in the electronic and medical record. All available scores lack complete external validation, but should be used alongside clinical identification of risk factors. And I hope in the future and next decade, artificial intelligence and machine learning will help us incorporating the risk assessment scores in the decision-making algorithms. Thank you very much for your attention.